So with that, I'm going to go ahead and introduce our next speaker, Dr. Ruth Shim. She will present her talk, Social Determinants of Mental Health and First Episode Psychosis, Seeking Mental Health Equity. This presentation will highlight the growth in the field, as well as the increasing complexity that must be considered as it relates to structural racism and oppression. Dr. Ruth Shim is the Luke and Grace Kim Professor in Cultural Psychiatry and Professor of Clinical Psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis. She also serves as Associate Dean of Diverse and Inclusive Education at the University of California, Davis School of Medicine. Dr. Shim received a Master's in Public Health and Health Policy from Rollins School of Public Health at Emory University and an MD from Emory University School of Medicine. She's a member of the Board of Trustees of the Robert Wood Johnson Foundation and the Scientific Advisory Council of Bring Change to Mind, an organization to reduce stigma and discrimination associated with mental illness. She serves on the Research and Evaluation Committee of the California Mental Health Services Oversight and Accountability Commission. She also serves on the editorial boards of multiple journals and is co-editor of the books, The Social Determinants of Mental Health and Social Injustice in Mental Health. In 2021, she was the recipient of a NAMI Exemplary Psychiatrist Award and the UC Davis Health Dean's Award for Excellence in Mentoring. She was named a Top 20 Black Changemaker of 2023 by the Sacramento Bee. Finally, Dr. Shim provides clinical psychiatric care in the UC Davis Early Diagnosis and Preventative Treatment, or EDAPT, Early Psychosis Clinic. We're so honored to have you here today, Dr. Shim. And with that, I will let you go ahead and share your screen.
Well, thank you so much, Sam, for that introduction. And I'm so pleased to be meeting with all of you and being here with all of you virtually. I'm just going to pull up my slides really quick. Well, I'm so pleased to be joining you all today, and I have a lot to discuss. And so I really do want to jump right into the topic because it's broad and we're attempting to cover a lot of information in hopefully just about 45 minutes so that we have enough time for discussion and questions afterwards. So today we are going to talk about many key concepts that are associated with the social determinants of mental health. We're also going to evaluate the recent evidence that has been made available about social determinants and how they drive first episode psychosis outcomes. And we're going to spend some time trying to identify solutions for achieving greater equity in first episode psychosis outcomes. So one of the most important things, if we're going to talk about social determinants of health, I think it's helpful to kind of see where the field has evolved because it's a relatively new field, but there's been a lot of change within the field of the science of social determinants of health over the years. And I say it's a relatively new field, but it could actually go all the way back if we wanted to the man who's considered the father of modern pathology, Rudolf Virchow. And he had a lot of great quotes. He was very focused on pathology, but also had kind of this public health bent. And one of the things that he said, one of the great quotes that he had, he said that if medicine is to fulfill her great task, then she must enter the political and social life. Do we not always find the diseases of the populace traceable to defects in society? I love this quote for a number of reasons. One, mainly because Virchow refers to medicine as a she, and that happened far before in a time where gender roles were thought of maybe a little bit differently, but maybe not that differently today. So I appreciate that. But also this recognition of the idea that politics and society and social life are very much related to how disease develops and how outcomes in certain diseases happen. And I think that's important if we're going to talk about how the social determinants of health and first episode psychosis are related. So a couple of definitions around social determinants. It started, this whole idea around social determinants started with the World Health Organization thinking in this concept and thinking about what is. And the World Health Organization defines health as a complete state of physical, mental, and social well-being, and not merely the absence of disease. And I think that's really important. It also relates to the presentation we just heard before, the idea that it is not just about not being sick, but it's really about this multi-level well-being at the level of physical, mental, and social. And so that first thought around social determinants of health relates to the idea that social well-being is just as important as physical and mental well-being when we're thinking about health. And then we can kind of fast forward a little bit to the late 90s, early 2000s, and we started seeing a lot of reports, all kind of associated with the World Health Organization around the social determinants of health. And so the people that I think were most instrumental in bringing the concept of the social determinants of health to the forefront were Sir Michael Marmot and Sir Richard Wilkinson, two British researchers and public health folks who you may also be familiar with because they developed the very famous Whitehall studies that looked at social class and how social class within an organization or a business, how that leads to health outcomes very directly. So these reports are kind of seminal reports that came out on the social determinants of health. And the one I really want to highlight is the one here on the right, Closing the Gap in a Generation. This was a report that came out by the Commission on Social Determinants of Health, which was put together by the World Health Organization and included experts all over the country. When this report came out in the early 2000s, or the late in the first decade of the 2000s, it was really phenomenal for me personally because I was trying to understand why I was seeing all these disparate outcomes, all these differences in how populations experienced illnesses. And I couldn't, at that stage in my career, really have the language or the understanding about what was driving that. And I started my career after I did my residency and I did a fellowship in community psychiatry. I started my career in academic psychiatry at Morehouse School of Medicine, which is a historically Black college and university and medical school in Atlanta, Georgia. And I was so fortunate because I got to work with Dr. David Satcher, who was the 16th Surgeon General of the United States. And then after he served in that role, he came back to Morehouse School of Medicine and developed a Satcher Health Leadership Institute. So this report was hand delivered to me by Dr. David Satcher at this very, very early stage in my career. And it was an instrumental report for me because it really explained health equity. It explained what the social determinants of health are. It defined it for me and it laid it out so clearly. And here's an example of a quote that came from that report. It said, "Social justice is a matter of life and death. It affects the way people live, their consequent chance of illness, and their risk of premature death." Again, before this, I didn't have the language to understand how social injustice connects directly to illness outcomes, how people live and how people die, and whether people have illnesses and whether they can recover from these illnesses. So it gave me a language and an understanding that I'm going to share with all of you today. But that was the starting point. And then, like most things in our society, even the social determinants of health became very politicized. And so there was this thought that if you want to talk about social injustice and if you want to talk about ills in society, that is a very political thing that you are attempting to do. And so what we also saw are reports around how do we talk about the social determinants of health without getting too political, without getting too extreme in the ways in which we think about these concepts. I could give a whole nother talk about the challenges of trying to do good work with the barriers that are placed in the way around politics, but that's not the talk we're doing today. So I will skip over that and just say that this was a report that came out again in the early 2000s by the Robert Wood Johnson Foundation about language that you could use to talk about the social determinants of health that doesn't have any type of political bent. And so you see these kinds of statements like, your neighborhood or job shouldn't be hazardous to your health, or health begins where we live, learn, work, or play, or that the opportunity for health begins in our families, neighborhoods, schools, and jobs. And so this was when you started to see the ideas of thinking about social determinants of health being married with narrative. And how does the narrative, how are you saying what you're saying about social determinants of health in a way that people start to understand it? And then, of course, this kind of got adopted and more widespread with the federal government and their Healthy People initiatives. And so the Healthy People 2030 initiative really centers social determinants of health and divides it into these 5 categories, including healthcare access and quality, and education and economic stability, and social and community context, and neighborhood and built environment. So there are all these ways to think about the social determinants of health. I'm even going to present another way to think about particularly the social determinants of mental health in just a second. But I also do want to talk, I mentioned that Dr. Satcher handed me this report, and this report was kind of life-changing at the beginning of my career, because what it meant for me is that I wanted to take all of this great information that was talking about the social determinants of health, and I wanted to specifically focus in on the social determinants of mental health. I wanted to make sure that we didn't forget that the same things that address physical and mental and social well-being also, we sometimes forget, and we sometimes don't center mental health in the ways in which we should. And so that was the work that Dr. Michael Compton and I did on this book that we published in 2015, The Social Determinants of Mental Health, where we were really thinking about how can we gather all of the evidence that exists around social outcomes and how they lead to mental health inequities or poor mental health outcomes. And in doing that work, and I'll explain this a little bit more as I go on, but in doing that work, I came to understand that it's not even just a matter of focusing on the social determinants of mental health. That's very, very important. It's extremely important. And we don't spend enough time focusing on the social determinants. But even more than that, there's all this stuff that comes before the social determinants of mental health that sets the context, that happens even further upstream than the social determinants of mental health, that creates the circumstances by which we see social determinants of mental health in our society. And then that drives mental health inequities and these poor outcomes that we see. And what that is, what's all the way upstream, is social injustice. And I'm not saying anything new here, because the Commission on Social Determinants of Health laid that out in their executive summary about how social injustice is such a driving factor for why we see poor health outcomes. And also, more importantly than that, they kind of laid it out so eloquently that on the back of that report, it says a quote that I often use, that social injustice is killing people on a grand scale. And so that was work that I wanted to connect and make that connection again to mental health. And so Dr. Sarah Vincent and I, most recently in 2020, put out this book on social injustice and mental health, to talk more specifically about what are those upstream factors that are creating the context for the social determinants of mental health. So I'm going to get into all of that today in the little time that we have. And so I'm going to kind of move ahead so that we can get to how those concepts kind of work and how it shows up. So we do have to define a few more things. And one of the things I feel like I always do in a talk is I spend a lot of time defining things. And it's really important for us to spend a lot of this time on definitions for a number of reasons, but I think most importantly, because these concepts are so often misconstrued or misunderstood, or we have kind of biased perceptions about what we're talking about. And so it's really important to focus in on some definitions here. And so the first one I want to talk about is this new concept that has kind of come out of social determinants of mental health, and that's health-related social needs. And so we're really talking a little bit about social determinants of mental health, but some people refer to these things as health-related social needs. And so they're defined as the social and economic needs that individuals experience that affect their ability to maintain their health and well-being. And these could include things like employment, affordable and stable housing, healthy food, personal safety, transportation, and whether or not people can afford utilities. And so this distinction here is between social determinants of health and health-related social needs is very important, because the way that it is thought by at least the federal government is that social determinants of health are community level factors, whereas health-related social needs are individual level factors. I tend to lump all of these things together, but it is important to know that people think differently about these concepts, and so there's different definitions out there. And then, of course, the social determinants of mental health are defined as the societal, environmental, and economic conditions that impact and affect mental health outcomes across various populations. And of course, that these conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And most importantly, that the social determinants of health and mental health are prominently responsible for the health disparities and inequities we see both within and among populations. So basically, this definition is saying that these conditions, these societal conditions that we live in, affect affect mental health outcomes. And it is our decisions collectively as a society about who gets money, who gets power, who gets resources, that drives those societal conditions. And then those societal conditions create inequities that we see in health outcomes. So that definition mentioned disparities and inequities, and I want to take some time to define those two things and talk about why I don't use the term disparities very often. I really only talk about health inequities. And the reason for that, it's not wrong to say health disparities. You see here that this definition of health disparities, which is also from the World Health Organization, is a very good one. Differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability, or where you might happen to live. Great definition. I think describes health disparities perfectly. But I do want to contrast that with this definition of health inequities, which are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And so I mentioned I don't really use the term health disparities very much. I really only talk about health inequities. And that's because as I have done more and more research and more thinking about mental health outcomes, but about health outcomes in general, I haven't really seen a lot of differences in health outcomes that are not the result of systemic, avoidable, and unjust social and economic policies and practices. They almost don't exist. And so if we are not naming what the cause of these differences in health are, what's driving differences in health, we sometimes have this tendency as a collective society to think that the problem is actually with the individual, that the problem is somehow located internally. Like maybe there are genetic or biological differences that are driving differences in health outcomes among certain populations or certain groups. Or maybe there are cultural differences between certain cultural groups, certain racial and ethnic groups, for example, that maybe they make different choices about health-related issues, and that those are the things that are driving differences in health. And we don't spend enough time talking about the systemic, avoidable, and unjust social and economic policies and practices that are really driving these differences in health. And just like a very quick example that I can give, as a psychiatrist, I think that I have seen and spent a lot of time looking at many studies that comment on the fact that rates of depression are far higher in women than they are in men. And so there is a lot of evidence to support higher rates of depression around gender lines. And what I have noticed in looking at the literature over many years is that many people take a health disparities approach to thinking about this problem. And so where do the studies go? The studies start to look for what are hormonal differences between men and women that might be driving depression, higher depression rates in women? What is the effect of estrogen? What are the other kind of like biological or genetic differences between men and women that are kind of deep-seated intrinsic differences that might be causing this problem? And so a lot of studies look at estrogen and testosterone to try to understand differences in depression rates among men and women. And very few studies look at or consider or really explore the fact that we live in a deeply patriarchal society in which women are highly oppressed and highly marginalized, and that we have many policies, many social and economic policies and practices that distinctly disadvantage women in our society, and that these unjust social and economic policies and practices are far more likely and make much better sense to explain the higher rates of depression, the fact that women are more likely to be victims of violence, and that violence is a risk factor for developing depression. All of these things kind of come into play in this very complex, multifactorial way. And sometimes our scientific methodology for trying to understand these things gets too simplistic, and it doesn't really think about the complexity of the systemic, avoidable, and unjust social and economic policies and practices that are really driving these differences. Okay, a couple more definitions. The next one is social justice. Again, an important thing to define because it has been misconstrued in many, many different ways. And social justice, at its core, this is a philosophical concept. And so these are definitions by philosophers. So one of the philosophers that really spent a lot of time thinking about social justice is David Miller. And this is kind of paraphrasing his thoughts about social justice, but he defined social justice as the distribution of good or advantages or bad and disadvantages in society. And so more specifically, looking at how these things should be distributed in society. So the decisions we make about who gets what in our society, who gets advantages and who gets disadvantages in our society. So it's concerned with the ways that resources are allocated to people by social institutions. So decisions we make about who gets advantages and who gets disadvantages. And then another philosopher, John Rawls, defines social justice as assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And this is so critical when we start talking about first episode psychosis, when we start talking about any serious mental health issue, any disabling mental health condition, because oftentimes, because of the oppression and marginalization that populations with mental health problems have, they end up becoming and forced into a position in which they are the least advantaged members of society, not by their own selves, but really by the way that society treats this population. And therefore, when we think about social justice, we have to think about how are we making sure we're caring for this particular population, and what are we doing to make sure we're taking the best care of this particular population within our society, those that are vulnerable, those that are more likely to be oppressed and marginalized than the average person. So that is work that I think we have to, when we think about social justice, I think it's really important for us to consider that concept. Okay, this is a conceptualization that myself and Dr. Michael Compton developed to explain the social determinants of mental health. It looks a little busy, but it's not so complicated. We're going to walk through it really quickly. The top of the figure is where we'll start. And as we move down the figure, and I know this doesn't make a lot of sense, but as we move down the figure, we're going to be moving further upstream. So each level on this figure is one step upstream. Don't ask me why I didn't flip the figure and like have the upstream. I've had that question many times. I have no idea. It's just how we thought about it. I don't know. Anyway, so here we are at the top of the figure, adverse mental health outcomes and mental health inequities. And one step further upstream from that is where we spend a lot of time thinking about in mental health, and particularly in psychiatry, I spend a lot of time thinking about risk factors, right? Because the whole idea is that a risk factor precedes an illness and increases the likelihood that somebody might develop that illness. And so, especially in thinking about first episode psychosis, we spend a lot of time thinking about people that are clinical high risk, people who have lots of risk factors that might increase their likelihood that they might develop psychosis. And so we spend a lot of time trying to intervene. And so those risk factors take on a number of different things, like behavioral risk factors, stress responses, psychological stress, and of course, the options that people have. Their options are choices. Poor choices is in quotes here because the choices we make are distinctly based on the choices that we have. So if you don't have a lot of options, you might be looked at as making bad choices, but you actually might be making a better choice than the best of a very bad set of choices. And an example I like to use a lot for this is how many people self-medicate with illicit drugs. I think that people would say, well, why do you choose to use drugs? But a lot of people don't have access to the mental health supports, and self-medication is a very effective way to cope with trauma and difficult situations that some people experience. Okay, so there we are at the risk factor level. It's further upstream. This is where I sit as a psychiatrist and as a first episode psychosis psychiatrist. This is where I spend a lot of my time trying to identify risk factors. It's how I've been trained. But as I think about that training and as I think about the work that I have been doing, I have come to understand over the many years that if we're intervening at the level of the risk factor, we're intervening too late, right? Because of all of that context further upstream, all of those things that kind of set the context for the development of the risk factor. And so all of those things that are further upstream that set the context are in these boxes in the center, and they are the social determinants of mental health. And so they include the things in these boxes that we see, like adverse early life experiences and discrimination and exposure to violence and conflict and interaction with the criminal justice system, and how much education you have access to, and whether you're employed or unemployed, and whether you experience poverty or whether there is significant income inequality. As well as things like homelessness and housing instability and food insecurity and transportation insecurity and poor access to healthcare, which is a big one in mental health. And then, of course, adverse features of the built environment, neighborhood disorder, which I'm going to touch on a little bit more in a minute, pollution exposure, and climate change. So all of these things, and this is not an exhaustive list, there's many, many more social determinants of mental health, but all of these things are these aspects that set the context for and the creation of risk factors. I mentioned Sir Michael Marmot and Sir Richard Wilkinson before, and they describe these things or call these things the causes of the causes, especially also Jeffrey Rose, Sir Jeffrey Rose, another British researcher. So they call these things the causes of the causes. Bruce Link and Joe Phelan call these things the fundamental causes of disease. But whatever you want to refer to them as, social determinants, fundamental causes, they are the drivers of these risk factors, and they lead to these adverse mental health outcomes and mental health inequities. But just as I'm thinking about the risk factors and the fact that intervening at the risk factor is intervening too late, I also have come to understand that even if we're putting our attention on the social determinants of mental health, we're still actually intervening too late, because there is a context that was created prior to the development of the risk factor that led to, of the social determinant that led to the social determinant of mental health. That there were all of these things that happened before that led to social determinants of mental health that you see in these boxes. And what happened all the way back, all the way upstream, that's where you actually get to unfair and unjust distribution of opportunity, or social injustice. And we could call that the causes of the causes of the causes. These are the things that are really driving the development of the social determinants of mental health. And underlying all of this, underlying social injustice, underlying the unfair and unjust distribution of opportunity, are two very basic concepts: social norms, or our beliefs that we have about people in our society, and public policies. So social norms, of course, are back to the idea that we think that some people are worthy of certain advantages and that other people, just based on their race or their gender or their sexuality, that they are worthy of more advantages or less advantages in our society. And based on those social norms and those beliefs that we have created about a hierarchy of human value, we create public policies, laws, rules, regulations, all sorts of ways to govern ourselves at all levels of our society that reflect those social norms, that reflect those opinions about who in our society is worthy of value and who is not. And so those public policies and social norms intersect with each other and interact with each other to create an unfair and unjust distribution of opportunity that leads to the social determinants of mental health, that then leads to risk factors, and then that leads to adverse mental health outcomes and mental health inequities. And this is a quote from a researcher that was asked to, by the United Nations, look at the problem of extreme poverty and human rights in the United States. And what he said, and this relates to this point about public policies that I was making on the previous slide, he said, U.S. policy he spent over a year kind of interviewing many different people in the United States, from the poorest people in the United States all the way to the richest people, to try to understand, why does the United States kind of very uniquely treat people in this way, in which we have a stronger hierarchy of human value maybe than some other countries. And he said that U.S. policies are deliberately designed to remove basic protections from the poorest, punish those who are not in employment, and make even basic healthcare into a privilege to be earned rather than a right of citizenship. And he, not being from the United States, found this to be kind of peculiar. I think many people in the United States would be kind of not surprised by this and say, yeah, like you should earn healthcare. You should be able to, it is a privilege, it's not a right. And so he was shocked by this, but it's an example of how these public policies can interact with social norms to create unfair and unjust distribution of opportunity. So I've been kind of dancing around this concept for a while. So I think it's important for us to define structural racism, because it's really down there in that core, thinking about social norms and public policies. It's important for us to talk about that. So structural racism is defined by the Aspen Institute as a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. It is a system that identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. So we're back to this idea of who in our society gets advantages and who in our society gets disadvantages. And when we talk about privileges and advantages and disadvantages associated with whiteness and color, you see this example here of these redlining maps, which very specifically assigned privileges to those communities that were considered to be predominantly white communities, and disadvantages to those communities that were deemed to be problematic communities because they were majority people of color and majority Black. And so it's important that structural racism is known as, that it's not something that a few people or institutions choose to practice. Instead, it's been a feature of the social, economic, and political systems in which we all exist, and it does not require the actions or the intentions of others. And that's really, really important, because oftentimes when we talk about racism, we tend to focus in on interpersonal discrimination. We tend to focus in on the one-on-one discrimination that exists, the one-on-one racism. We hear about this all the time in the news. But if we got rid of all of the interpersonal discrimination that exists in our society today, we would still see racial and ethnic inequities due to the persistence of structural racism. So it's not enough just for us to personally be better, personally interact with people in a non-racist way. We actually have to think very thoughtfully about how do we start to dismantle the structures that have been built in our society that exist because of policies and practices that are rooted in structural racism. So here's a couple of important concepts that are associated with structural racism, and that is oppression. And this is work by Iris Marion Young, who described the 5 faces of oppression. She talked about exploitation, which is the unequal exchange of one group's labor and energies for another group's advantage and advancement. Examples of this, of course, we can think of slavery, but there's many examples of this happening in modern day. And we think about like the treatment of migrant farm workers, for example, but also like the treatment of people working in warehouses and being trafficked. There are a lot of modern day examples of labor used for particular people's advantage and advancement and really disadvantaging others. Cultural imperialism is when we establish the ruling class culture as the norm and we other those groups that are not part of the dominant culture. I see this all the time in research. This is like a really common thing that I notice in research. And so if I'm looking at a paper that's describing racial differences, looking at, they might call them disparities, I might call them inequities between racial groups. Oftentimes I'll notice there will be kind of odds ratios, which are comparing which group has like the higher likelihood of having a particular disease. And what I've noticed over the years is that these studies, you have to have kind of a reference group. You have to have one group or one population that you're comparing the others to in order to get that odds ratio of what's most likely, which one who is more likely in that population. And so when looking at racial differences, I have noticed in every study that I've looked at that the reference group is always white people. And it really doesn't even matter if the white people in that study were not the majority of people in the study. It's that we kind of automatically think that we should compare people to people of color to white people because we kind of see white people as this default norm, and that we should then compare everybody else to that default norm, even if they're not the most dominant person in that particular group. So these are the ways in which cultural imperialism kind of feeds into our societal experiences. Powerlessness is when oppressed groups lack power and are blocked from routes to gaining power. This is one of the most effective ways that we see that certain people do not have the ability to represent themselves in government, and why we see policies that particularly prevent certain people from voting and certain people from having appropriate representation. Marginalization is when we expel specific groups from meaningful participation in society. And that is, kind of very clear. I think the best example of this is treatment of indigenous populations in this country, but we have a long history in the United States of treating many different racial and ethnic groups through marginalization by expelling them. We can go all the way through the Chinese Exclusion Act and Japanese internment, all the way to modern times in which Black and Brown populations are being the mass incarceration of Black and Brown populations. And then violence are threats and experiences of physical and structural violence. So that kind of speaks to itself. The one thing I will say about this is that you can see violence kind of show up in an intersectional way. For example, if we think about transgender populations and transgender people of color, they are far more likely to be victims of violence at epidemic rates in this country, and in ways in which we don't see a lot of outrage about the level of threat of physical violence that transgender people of color experience in our society. So examples of a highly oppressed population. Here are several examples of how structural racism shows up. And we don't have enough time to kind of go into all of them, but I am going to spend some time talking about how structural racism shows up as it relates to first episode psychosis. And the best example of this is a historical example, but I am going to kind of take this into the current times. And the historical example relates to this concept of the protest psychosis. This was a book written by Jonathan Metzl in which he spent extensive time at a psychiatric institution in Michigan. And he pored over the records of this institution over a number of decades, from like the 40s and the 50s all the way to the 70s and the 80s in this hospital until the hospital closed. And so this Ionia State Hospital that he was in kind of helped him understand differences in the ways in which the diagnosis of schizophrenia has changed over time. And if you can even see in this timeline how significant the way we think about schizophrenia has changed over time. All the way back before the 50s, the DSM-1, the first kind of description of schizophrenia, described it as a disease of people with weaker minds or sensitive dispositions or personality disintegration. This is really important when we're talking about social norms again, because if we're saying that these people have weaker minds or sensitive dispositions, we start to make judgments about what they can or cannot do or how they can or cannot participate in society and whether or not they're worthy of advantages or disadvantages. We move on to see the first ranked symptoms by Schneider and the discovery of antipsychotics. And then that DSM changed in the late 60s because we started the DSM-2 focus on those first rank Schneiderian symptoms and emphasizing things like inappropriate emotional responsiveness and loss of empathy and bizarre behaviors. And then the paranoid subtype came in the late 80s. And then in 2013, all of the subtypes were removed from the DSM-5. All of this becomes really important when thinking about Ionia State Hospital, because at the time that Metzl started looking at the assessments of people, he noticed that most of the people that were being admitted to Ionia State Hospital were white women. And most of these white women were being admitted with a diagnosis of schizophrenia because they were not operating in their family unit the way there was an expectation that they should. So some of the kind of chief complaints that came in for Ionia State Hospital at that time were that these women with schizophrenia weren't able to take care of their family as she could. She can't do her housework. She talked too loudly and she embarrassed her husband. And Metzl has this great quote here. He said, perhaps she rebelled against a patriarchal system and a patriarchal diagnosis that allowed white male doctors and her white male husband to be the arbiters of her mental health. However, the most important aspect is that her defiance was interpreted as a symptom, but not as a threat, right? So there was no thought that these women that were being diagnosed with schizophrenia were dangerous. There was no thought that they were hostile. There was none of that. It was just they weren't keeping up with their wifely and motherly responsibilities, and therefore they got this diagnosis of schizophrenia. So at the time, the conceptualizations of schizophrenia did not talk about paranoia, aggression, or hostility. Instead, it was this disease that people felt came from early life psychological trauma, again, kind of implicating the mother, that a schizophrenogenic mother was the person that was kind of leading people to develop these schizophrenia diagnoses. And so the protopsychosis is very interesting because that came along in the mid-60s. And it was this idea described first as this reactive psychosis by these two researchers, Romberg and Simon. And they said that this type of psychosis was commonly seen in Black males as a result of the stress of asserting civil rights in the United States. So they were saying that they were seeing these men who were participating in the civil rights movement start to develop these psychotic symptoms. And they likened these symptoms to schizophrenia, and they described them as hallucinations of African themes, adoption of Islamic doctrine, and promotion of anti-white mindsets. And so they said that, that these Black psychiatric patients that they were seeing had higher measures of hostility than white psychiatric patients. And they said that that hostility came from these delusional beliefs that their civil rights were being compromised or violated. So I think it's important to notice here that these white behavioral health providers were interpreting behavior, which was fighting for civil rights, as delusional context. As that these people that were fighting for their civil rights were delusional because they had this false belief that their civil rights were being violated. So what you saw with the protopsychosis was this pathologizing of the tenets of the civil rights movement by equating those ideas with paranoid delusions. And it really allowed certain sectors of society a mechanism for removing threats to the status quo in the name of safety and mental health. So this idea that psychiatrists and psychologists and clinicians had the power to kind of make judgments about behavior, pathologize those judgments, and then lock people away in psychiatric facilities for behaving in a certain manner. And so what Metzl says is that the protest psychosis joins with a racial unconscious identification to attack, sorry, that Metzl didn't say this, Bromberg and Simon said that the protest psychosis joins with a racial unconscious identification to attack the traditional values established by white humanity. So again, social norms about who in our society is, who has the correct values, who has incorrect values, led to policies in which we changed the very definition of schizophrenia and psychosis, which then led to a number of outcomes, a number of important social determinants of mental health. The first being that there was this widespread consideration that Black men were getting diagnosed with schizophrenia and were seen as hostile, assaultive, belligerent. The ads changed to kind of describe this. And we started seeing at that time and persistent into modern day, more Black people and Black men in particular being prescribed medications like Haldol for psychotic illnesses and even not for psychotic illnesses. So just far more people being prescribed medications like Haldol if you were Black, and particularly if you're a Black man. And so in the 80s and the 90s, we saw Black men being diagnosed with schizophrenia and paranoid schizophrenia in particular at a rate 5 to 7 times that of white men. Not because there's some underlying biological difference between Black men and white men around schizophrenia, but really because of the interpretation, the idea that certain behaviors were being interpreted as problematic behaviors. And so you saw this kind of continue. And even today, we see that Black patients are more likely than white patients to be considered higher risk for violence, more likely to be hospitalized involuntarily, more likely to be secluded and restrained, more likely to be administered higher doses of antipsychotics, and more likely to be administered medicines against their will. So when it comes to thinking about first episode psychosis, we can go back to the history of the 1930s and talk about Ferris and Dunham. They looked at Chicago and found this relationship between social disorganization and schizophrenia. So in the areas of Chicago, in the communities of Chicago that they defined as more socially disorganized, higher density of people, more kind of less organized socially, that they saw higher rates of schizophrenia in those populations. And I would say that the researcher who's doing the most effective work on kind of seeing the connection between social determinants of mental health and ethnic density and social disorganization and psychosis risk is Deirdre Anglin, who is really like just doing some really exceptional work in this space. And so you can see from these studies, she's really looking at the connection between social determinants of mental health and how that leads to increased psychosis risk. And in the study in the bottom here, she's talking about how people who had young people who live in higher rates of ethnic density, of people among their own racial and ethnic identity, had risk for clinical high risk of psychosis, ended up not converting to psychosis at a higher rate than people who lived in areas of lower ethnic density. And the hypothesis there that she did a really great job of proving is that those young people experience less perceived discrimination, were living in neighborhoods that had more people that looked like them. And so that lower rate of perceived discrimination was actually protective in having people not transition to from clinical high risk of psychosis to early psychosis. She also shares like a very deeply personal experience that she had in which she was mistaken for being psychotic. And there was racism when she had a health issue that really kind of made it more complicated for her to get the care she needs. So all things to consider and talk about. Okay, in the time that we have left, and it's not a lot of time, so I'm going to just fly through. we're going to talk about how to solve all these issues. Very easy stuff. So here we are, we're in this state of inequality, unequal access to opportunities. And a lot of people would say that the goal, and I think many people in our society, they look at these problems and they say, well, the way that we solve these problems is we focus on equality. And equality is really when we're thinking about evenly distributing tools and assistance. Equality's most important goal is fairness. And you can see this at work with a lot of policies trying to intervene. It is, we can make changes and we can try to improve things, but we can't do anything different for any population, right? So if we decide to make an intervention for one population, we have to make sure everybody gets the same intervention. We've seen that recently with Supreme Court decisions and things like that. So equity is really a far more effective strategy for addressing this problem than equality. Equity is when you customize the tools to identify and address the inequality. So you're giving that particular population what it needs to try and address the problem. And so that can help, but you can tell with this figure that it doesn't fully solve the problem, right? It's a starting place, but it doesn't solve the problem. And so what we really need to think about is, how do we combine equity with justice? And justice is when we focus on fixing the system to offer equal access to both tools and opportunities. So we're really making sure that we're addressing the systemic issues so that people get equal access to both tools and opportunities. How do we do that? Well, we go all the way back to the source. We get to these social norms and these public policies. And so if we're going to promote social norms of inclusion and equity and respect, we have to promote narrative change that prioritizes the inclusion and respect of all people. We have to educate or legislate to change negative social norms about certain populations. I say educate or legislate because sometimes education can be effective. In other ways, we have laws and policies that prevent the discrimination of certain groups, and we should use those when education does not work. We need to observe and challenge our own implicit biases, and we need to evaluate and break down unnecessary hierarchies. I love this quote from Toni Morrison. She says, definitions belong to the definers, not the defined. I spent a lot of time defining things, but we need to think about how are we changing narratives? How are we taking control of the ways in which we think about these things? If we're going to work on public policies, we have to take action beyond the walls of our clinics or hospitals or treatment centers. We have to advocate for policies that address social determinants of mental health. We have to communicate with our elected officials and promote equitable representation. And I think most importantly, we have to form cross-sector collaborations and community coalitions, and we have to center the voices of people with lived experience. This is something that is missing in almost all of the ways in which we attempt to solve problems in our society. We do not give power or voice to the people who are most impacted and most affected by the decisions that we make for people, because we decide that they are somehow incapable of making decisions for themselves. So giving that power back to people who have personal and lived experience is incredibly important. This is just an example of how policies and spending actually matters. And so those countries that spend money on social care programs have higher life expectancies. And the US spends a lot less of its money on prevention than almost every other high-income country, less on prevention and less on social care. And our poor outcomes, I think, are the result of that. So this is work that is important for us to do. I'm going to stop right there so that we can have a discussion and take some questions, and end with this beautiful quote from Maya Angelou, especially since there are attacks around diversity throughout the country, but it's important for us to remember that in diversity, there is beauty and there is strength. Thank you.
Thank you so much, Dr. Shim. This was exceptional. And I don't know if you've been able to kind of see the chat as things roll through, but I just want to reflect how much people were moved by this presentation. We had a number of folks saying this was the best social justice presentation that they've ever attended, and really thankful for the way that you shared all of the definitions and made that really accessible in those definitions. I also just wrote down there were a couple of quotes that really resonated with our audience, and I wanted to share those back with you that were typed in the chat box. So, the choices we make are based on the options we have. And if we're intervening at a risk factor, we're intervening too late. And so I thought that was really powerful just to share with you kind of what resonated with our audience. We also got a number of questions. And so we'll probably have time to take maybe two, depending, well, maybe three, depends kind of how much we want to say. But the first question was from an individual provider who was thinking about assessment and making sure that they're assessing for social determinants of health when they meet with folks in a clinic or a health setting. And if you have any recommendations for assessment or kind of how to holistically think about making sure that we know what someone's social determinants of health look like.
Yeah, that's a great question, and I think it's important to I think providers are tasked with doing so much in a encounter that it becomes so challenging to do this, right? But it's so critical. Just a little story example that I will give. One of the things I learned kind of probably too late in my career is that I would spend all my time doing my full assessment and talking to the patient and trying to understand what was going on and like checking off symptoms. And then I would say, okay, I'm going to prescribe you this medication and it's going to be great and you're going to get better and go on your way. And many of my patients would never take the medication, never, ever, ever. And so what I started thinking about and what I started realizing is that I had to shift the entire way that I did an assessment because I had to have enough time, way more time than I thought, talking about every last detail about a medication, like why I'm prescribing it, why it's really important, what the side effects are, how it might, what are your concerns? I needed to have enough time to really ask the person, like, do you have concerns about this medication? And let's talk about them. And there was often a lot of time that was needed. And so all that time that I was spending gathering all the information was not nearly as relevant or important as the time that I spent listening to the patient about like what their concerns were about treatment. And people have lots of concerns. And so it's the same way. I think we don't spend enough time asking about what are the social and environmental factors that are going on in your life? What are all of the things that you're experiencing in your life? But that's actually far more important than the symptoms, I think. And so there are lots of screening tools around social determinants of health. There are health-related social needs screening tools. So there's individual level stuff. How much food do you have access to? And then there are like more population level. I would also encourage people in wherever they are working, in whatever environments they're in, to really come to understand what are the demographic what's the demographic information? What is the incidence of food insecurity in the zip code that you're in? How many people have access to transportation in the neighborhood that you're in? So like it's really a matter of kind of like educating yourself on what are the social determinants of the community that you're in and what is missing and what's not available, but also then kind of asking people and spending a lot of time focusing in on like what are these things. So yes, there's screening tools and I would use them, but more important than even screening tools is just opening the conversation to be able to talk about, well, what are the things going on in your life? What are the barriers and challenges and what are the what's your day-to-day life like? What is that like? And what are the things that are like getting in the way of you living your best life?
That's wonderful, Dr. Shim. And I think we're seeing a lot of appreciation for that in the chat box. And folks are talking about needs assessment of the community and knowing the community that you're in and what the predominant sort of social determinants of health that you might want to evaluate for specific to your area. And we did also have some conversations about rural areas in the chat box as well. So,
Right.
so I think that was fantastic. So you ended on this really powerful note of centering lived experience and that we don't do that enough in our systems to be driven by individuals with lived experience. I would love if you could talk for a minute about kind of what you see as the first steps in doing that, particularly if you think about integrating diverse voices of lived experience, right, and social determinants of health and health inequities as your presentation focused on.
Yeah, I have a lot of thoughts about this. I think we can think of people with lived experience, and particularly people with first episode psychosis or people with psychosis, as people who are a category of highly oppressed people. And that is just the policies kind of reflect the policies are, it's very, very hard for people with early psychosis to get treatment, right? That's a policy decision that we've made as a society. So it's back to those social norms, those public policies. We made those decisions. We decided a long time ago as a society that we weren't going to value mental health care in the same way that we value physical health care. And we don't really value physical health care very much. And so we decided that even though we don't value physical health care much, we're going to even value mental health care even less. And so we see the results of that. But what I have been noticing recently, and what I've been spending a lot of time thinking about, is all of that oppression then means that people with lived experience do not have the same opportunities to be successful in society as people without. And so there are so many barriers, even like, I would say very basic barriers, for instance, like becoming a peer support person. There are so many barriers to successfully becoming a peer support person, including the very, very little pay that peer specialists get. They get very, very, very little pay, right? So again, we put this like very small value on incredibly important work, which I think is incredibly important work of being a peer specialist. We do not value it, and we make it very challenging for people to live and like be successful in society if they choose a career like that. But I also have been thinking a lot about how complicated it is for those people, the very, very small minority of people who have first episodes, like who have psychosis, who are able to make it through college and medical school or a PhD program, and they go off into those experiences. And then there is so much additional oppression that makes it almost impossible for them to be successful. So there are all these barriers. And I noticed this in my job as an associate dean of diversity. There are all these barriers in medical school for people who have lived experience with any mental health condition that makes it very, very difficult. We've decided, I think collectively as a society, that we do not value people that have mental health problems. And so our policies reflect that. And so one of the things I think we have to focus in on, if we are going to center the voices of people with lived experience, is we have to collectively consider how are we going to remove the barriers and stop the oppression of people who have lived experience with psychosis, but also all other mental health problems as well. And so I'm thinking about, so one of the things I spend so much time thinking about structural racism, and one of the, and particularly racism that is inflicted upon Black people. And sometimes criticism that I get is, why do you spend so much time focusing on Black people? And for obvious reasons, of course, but also I think most importantly, because the pattern of one group that has been so terribly oppressed can be applied to every single group that has experienced oppression in our society. And so the ways in which we see people mistreating and devaluing and dehumanizing Black people is the exact same ways that we see people mistreating and devaluing and dehumanizing people with lived experience. And this idea that people with lived experience do not have the ability to contribute to society in the same ways as other people, all of that, our discrimination of people with disability, any disability, like all of that is kind of wrapped up in all of this social injustice and oppression that we experience. And so the fight for social justice and the fight for equal rights and opportunities as a means to address health inequities, it's the exact same fight. And so the fight for people with lived experience to be centered, to be at the forefront of making decisions around health and around mental health, that is the same fight. That is the same exact struggle. And so the interventions are the same. So it is about kind of organizing at the level. It's also about kind of pooling the resources of people with all types of oppression together and forming coalitions and making sure that people with lived experiences are also working with the same people that are working on racial equality, and the same people that are working on gender equality, and the same people that are working on equality for LGBTQ population. So all of that is the same work, and figuring out how we can kind of what I say is we just need like a small revolution, but we have to like start this kind of revolutionary process in which the people who have been oppressed, and it's many of us and probably all of us, that we start to take control and we start to take power and we start to kind of dictate how society will be run.
I love that, Dr. Shim. I think that's such a powerful note to end on, that idea of solidarity, right, across these movements, and how do we foster and cultivate that solidarity as a community across movements. And I just want to say you got a lot of notes in the chat box from peer support specialists just thanking you for echoing their work and highlighting the work that they do and the importance of that work. Really just wonderful. A lot of people are asking about how they share this knowledge more broadly, how they have this knowledge, and then how they share it with their teams and their community. So just want to thank you so much for being with us today. We could probably talk all day about this, but unfortunately we do have to send folks on their break and go into presentations for the afternoon, which will actually pick up really nicely on kind of anti-oppressive efforts with Leah Giorgini. So we will take the next 15 minutes. We'll come back at 2:30 and we will play some music and artwork, and then pick back up with Leah Giorgini at 2:30 p.m. CST. So thank you all so much for being here. Such a pleasure, Dr. Shim. Thank you again.
Thank you all.